We have with us Dr. Vikas Mittal. A big hello to you, who's the founder of the LG Eye Institute from Ambala City and is a greatly innovative surgeon and brings out a lot of newer procedures and makes the cornea surgeons envy him. And he's going to be talking to us failed graft, DMEK versus DSEK, when and how. So on to you, Dr. Vikas.
Thank you so much, ma'am. And it's really a privilege and it's lovely to see everyone here. And thank you so much for organizing this webinar. So from immunosuppression and all, we'll come to the hardcore surgical thing in cornea. So my topic is endothelial keratoplasty in a failed graft. So why do we want to really talk about this? So I was just going through my archives, and this was the first EK in penetrating keratoplasty that was done by me. It was close to 12-13 years back. This patient had penetrating keratoplasty done by steel sutures, and she had come to me with this graft edema. I did a DSEK. This was my first DSEK in a failed graft, and I was really thrilled to see when it got cleared within 20 days. So as cornea surgeons, we do come across these failed grafts where the cornea is primarily edematous, and when we do an EK, we want to see our cornea to look something like this. Definitely, we don't want our cornea to look something like this where the graft is floating, the cornea is still edematous. So looks like that this topic is important. And so I'll just go through a few points that how best we can have the outcome which are, better. Of course, we are not dealing with these opaque grafts where you'll have to change it and we'll have to do penetrating keratoplasty. What I'm going to touch upon is grafts like this, where it is edematous, endothelium is not working, and that's why this edematous cornea is not reflecting the light well. We know that majority failure are endothelial failures, and this can be secondary to the multiple rejections. So once rejection is there, it can kill that endothelium. Or primary failure, surgical trauma. During the surgery, you have rubbed off this endothelium, or the endothelium got damaged. Or to start with, the graft who had a poor donor endothelium. Or there can be secondary failure, which is like progressive endothelial cell loss. Suppose after 10 years, 15 years, the cell slowly went down and ultimately the graft became edematous. So this is what has happened. So failed graft can be a failed PKP graft, or it can be a failed EK graft also. I'll cover both of them. Let's start with PKP. So I have divided this PKP part into pre-op, intra-op, and post-op, and what are the key factors that we have to look upon when we are dealing with these kind of patients. In pre-op planning, so if there is one investigation that is very important, these patients as anterior segment OCT. It's very, very important, which helps us to plan our cases well, because many times it's not only DSEK that you do or DMEK you do, you'll have to deal with some associated procedures as well. Then as far as prognosis is concerned, what was the indication for PKP? It was a high risk. If it was a high risk graft, then the survival will be poorer. If the patient had glaucoma or status was GFS, AGV, again, this will have some borderline prognosis. Of course, you'll have to do B scan to ensure that everything is right back there. So regarding this anterior segment OCT part, I'll just show you a few examples of what I'm talking about. Sometimes you, along with the DSEK, you'll have to do a cataract surgery or phacoemulsification. Sometimes you have this membrane, you can see it is membrane, the tight membrane over the iris. This patient had therapeutic PK. So maybe the initial inflammation, it has covered the whole iris. So you'll have to deal with this part also if you want to do an optical, make this graft optically behave well. And sometimes you have RCM or retrocorneal membrane. So when you are doing desmetorexis, you might have to remove first RCM and then do desmetorexis if you want. And many times, this is very important. The posterior graft-host junction, it is really ragged. So you need to take into account when you are planning your graft size or other things. So in pre-op, the main important part is the anterior segment OCT, so that you know that what you are going to deal with when you are going to do your endothelial keratoplasty, what else you're going to come across. Intra-op, suppose now the patient has taken to OR, what you are going to do. There are two things that comes in our mind and we have to take decision on is whether you are going to strip DM or not in host, and what will be the diameter of graft. These are the two things which generally are important. Technique is like totally personal. You want to do a DSEK, TSEK, or sheet glide, bruising glide, DMEK, whatever. So that depends on whatever surgery you are comfortable with. it's important that we are going to talk about a bit about the incisions and air retention also. So I'll show you a video and then we will discuss it more. So this patient had a therapeutic graft. You can see the large graft. So first I'm doing is removing that epithelium so that I have a better idea of, I can see that well. And now what I'm doing here is measuring the, just 1 minute, this I missed. So this is very important. So I'm measuring what is the graft size that I'm going to use. So I'm going to use smaller than this PKP graft. So I want my EK graft to be inside this old graft. Since it was a large graft, I have to make an incision within the graft. Although I would personally prefer if I can have these incisions in the host area. So now there was an RCM here, you can see. So that's why I'm doing this decimeter axis, and this decimeter axis will be within the graft host junction. You don't want to go near the graft host junction, so that because this PKP graft will be the best attached at the epithelium and at the endothelial level. So after removing that RCM, there was some desmoid membrane that also had been removed. So now I generally make incision superior-nasal, and I generally use Busson glide for loading. I intentionally have made a thinner graft so that it drapes the posterior part of my PKP graft well. And then while using a crocodile forceps, it's pulled inside the AC. This is the superior temporal area, and AC maintainer is on, although the bottle height is down at this time. And once the graft goes inside, the ACM is removed, and ensure that these patients, you'll have to ensure that air stays that well, because this will be slightly on a higher risk for detachment. So we, in generally these cases, we ensure that the air remains there for 2 hours. And if there are this incisions which are leaky, ensure that I make sure that I suture all these incisions so that the air doesn't leak out. I want to ensure that the graft retains there for at least 2 hours. And after that, you can do air VSS exchange, and then this was the patient how we did very well. So in case, there are a few cases where you don't have to do desmoter access at all. And there you can do an DSEK. DSEK means you don't strip off the DM and straight away put the graft in. So what do we follow is that, suppose if you have KPs or iris pigments bang in the center, it's better to do a desmoter access. You have to ensure that at least 2 to 3 millimeter inside the GHA. If the endothelium is clean, means it is a progressive it's a failure due to progressive endothelial cell loss. There you can go ahead and do a DSEK. This is a patient who had undergone a DSEK, again a failed PKP. PK was done, I think, close to 8-9 years back. Same, first epithelium is removed to ensure that I can see everything well inside. And here, this is what I was talking about. I always prefer if I can have my incision in the host part. In the previous case, the graft was very big. So here, all the incision, the side ports, the port for AC maintainer, everything we are using in the host part of the cornea. Measuring how much diameter of graft I want to use. I want to use this diameter less than the diameter of PKP. Then entry also is just before the GA junction. So we don't want to touch the GA junction there, or try to avoid as much as possible. Then the same part, graft on the Busson glide and air, and ensure that the air stays well for good 2 hours. And in case you that's it. Okay, this was the same. So DM stripping or non-DM stripping is pretty clear. So if your endothelium doesn't have its clean, you can go ahead and do an DSEK. Diameter is very important. So there are studies where they feel that that the graft should be smaller than the PKP graft. But price group, they are very fond of putting a larger grafts, and they feel that if you put a larger graft, the more number of endothelial cells that goes inside. So there is no consensus. So what I feel is basically the posterior GHJ that is important. So sometimes you have a smooth posterior GHJ. There's a cakewalk. You can do DSEK, DMEK, whatever you want to do, or whatever size you want to choose. But sometimes you have this kind of GHJ, specifically posterior part. If you have so much ragged kind of thing, you have to be careful with your diameters. In these kind of eyes, it's better to use graft which is inside your graft host junction. So suppose you have a thicker graft and it is larger than the graft size, the PKP size. What will happen is there will be some area, potential area from where the aqueous can go inside and, cause the graft detachment. And it's possible that next day you'll see something like this. So it's better that, if you can have an access to anterior segment OCT, do it. And if it's a direct posterior GHJ, better to use graft within inside. And if you don't have OCT, I personally would suggest that have a diameter which is smaller than the graft host junction. Or in case you want to have a larger graft, ensure that you can have ultra thin graft. Yeah, sure. And similarly, you can do a DMEK also. That depends, how much you are comfortable with it. What we do is, if you have a clear case, you don't have to do any associated procedures. Then we do DMEK. But if you have to remove some, RCMs, or there is a possibility of some fibrin, then we prefer to do a DSEK. Post-ops are same. These are slightly high risk. So specifically, if there is vitrectomy associated. So these are the parameters of pre-op, intra-op, and post-op. And I'll just touch upon what do you do for the repeat DSEK. So what happens in repeat DSEK, what is important is descemeter access. So what happens is the endothelium, it crawls and it secretes its own DM. So you get an adhesion somewhere here. So it's important to do a descemeter access just beyond this the graft. Otherwise, if you can pull it, you might pull the whole base of the iris. So this is what I want to tell, that, so you do a descemeter access all over, ensure that all adhesions are cut before you try to pull this DSEK graft. So that is very important. And once those adhesions are cut, then it's absolutely, cakewalk, and you remove your old graft and put a new one with whatever technique you are, comfortable with. And the agent repeat DSEK, they do very well. And you can do a repeat if you have a DSEK and it's a clean case. This was a failed DSEK, although it was everything clean. So we went ahead, cutting off all the adhesions all over, then removing the DSEK graft. And this is the incision. And here we had done a routine DMEK. So if you just have to ensure that all the DM tags are removed, or when you want to do a DMEK in these kind of cases. And this is just a simple routine DMEK. And this was how the patient looked like. My last video is, this patient had failed PKP, then failed DSEK as well. So I just want to tell you that, sometimes removal of this DSEK graft becomes very tricky. So you have to ensure that, adhesions are cut. It's still, it's still there, but you must not pull them unless these adhesions are cut. So there were PS also. I am trying to use a reverse Sinski, trying to pull, very gently. But so I'm going inside. I went into the interface, and from that interface, I cut all those adhesions. And still in this area, it's still stuck. So there you can use your, crocodile or reverse MST to pull it. Here also, you need to be very gentle and ensure that you don't pull that base of the iris. And once this graft is out, rest is routine. So before I close, so I found some study where they found that if you do a repeat PKP for a failed PKP, this do better than EK. And there are studies where they found that EK is better than PKP. And then there are studies where they found there's no significant difference. And this meta-analysis showed that, because there's heterogeneity of these cases, so we are not very sure. Although those of you who are doing PKP for failed PKP graft is definitely not a crime. So thank you so much.
Thanks a lot, Dr. Vikas. That was so interesting for me too. So I can imagine how it would be for all the audience watching from there. So Shreyas, on to you.
Thank you so much, Dr. Vikas. I mean, amazing set of videos as always, and so interesting to hear you. One thing, being a proficient DSEK as well as DMEK surgeon, because failed graft, like you already showed in your example, is such a heterogeneous variety, unlike the PBKs or the Fuchs, which are much more predictable. What is your preference of choice? What makes you choose a DSEK versus a DMEK? Apart from, of course, you did mention highlighted altered posterior corneal curvature, I mean, graft host junction. But apart from that, what are the other criteria which helps you choose when you're examining the patient on a slit?
So what I generally see is, if in this patient while surgery there are chances of increased fibrin, or suppose there's a RCM, there is PAS, and I'm going to break this PAS and it will bleed. Those kind of cases, I do DSEK only. And I always very careful that I do an ultra thin DSEK in these cases. So for failed PKP graft, I think my DMEK would be somewhere around 10 to 20%. 80% of them are DSEK only. And it's simple, as you rightly said, that these are not like PBKs or fuse. Most of the time, there is some or the other thing also. Sometimes you have to put iris hooks. You have to do a phacoemulsification along with it. And sometimes the view is really bad. Though if your view is bad, you get a fibrin and you have, injected your DM inside, you'll have it. So for me, it's only the clean case, where that everything is fine. So those kind of cases, we can definitely do DMEK. Otherwise, majority of them we do DSEK.
Wonderful, sir. I mean, I think very nicely summarized. And any point you'd like to add, Sunita madam or Dr. Rajesh Sinha? Yes, madam.
Yeah, I think Vikas covered all aspects of nuances of choice between the two procedures very well, very comprehensively. One more thing which I would just want to add, which I feel is also relevant in this context, is to look at the age of the prior PK donor. Like, let's say if the prior PK donor was less than 40 years. So if you have to have a choice between DSEK versus DMEK, as such, the failed PK situation is a higher risk for detachments. As Vikas pointed out, like important and relevant, because the membrane has a very high risk of detachment if you traverse the graft host junction. So those cases where let's say you use the cornea for the first prior PK, which is less than let's say 40 years. So we understand how difficult it is to strip these Descemet's membrane. So quite often, if you have to strip the Descemet's membrane, which is sort of a requirement, not like an absolute, but it is a requirement for DMEK, you end up causing tags in the posterior membrane. And these could additionally increase the risk of detachment. So those would be the other important thing in the preoperative assessment. Like if you have the details of the prior donor, will be good to add.
True. Agree.
Dr. Merle had something to add. Yes, Dr. Merle, can you tell us?
Yeah, so I was just mentioning about the need for suture removal. Sometimes you have significant amount of astigmatism that is pre-existing in these grafts. And it's important to have an understanding about that, because once you put in the DSEK lenticule and the cornea clears up, then you have a lot of astigmatism post-op, which doesn't give such a great visual outcome. So that may be something that we could look at by doing, say, a pentacam, particularly if the surface is not too irregular. That will give you an idea about where the sutures are tight, and maybe we could actually consider suture removal prior and then proceeding with the DSEK.
Yes.
True.
Another thing, I just wanted to add one thing, that if you have a large graft, then it's not a big issue, like a large failed graft, then it's not a big issue. The problem arises when you have an optical PK which has failed. There's a 7.5 millimeter graft. There you have a problem when you have a graft host junction, which is, the posterior lip is dipping posteriorly, as the OCT that Dr. Vikas had shown. So that is one issue. The other thing is that graft survival definitely will be better if we do EK. But sometimes if it's a long-standing failed graft, then the surface and the stromal clarity is not that great in some of the cases. Even if the graft is absolutely fine, the thickness is fine, but still there is some little bit of haze there. Sometimes you do feel that, maybe PK was a better choice in that. But if it's a large failed therapeutic graft, then obviously, as Dr. Merle was mentioning, we have to look at the astigmatism. But if it's not significantly there, then maybe EK is a better option in those. But something like a small grafts previously, it creates some issues.
So maybe a theoretical question: if it's a failed PK and then you have done a DMEK, and then would you, and a repeat failure, then would you do a repeat DMEK or would you do a DSEK only in those cases?
So that depends, if the case is clear, you can remove your old DM and put a new DM. It's absolutely no problem. So if you have done a DMEK, yes, Dr. Sinha, you want to say?
It depends on how much duration it was there and how much clarity of the cornea is there. Sometimes if it's a very long-standing failed graft and then the patient has come to you and it has become very much edematous and hazy, then maybe DSEK will be a better option. Otherwise, you can just remove the DMEK roll and put another roll.
True.
Thank you. So we go on to our next speaker,
Yeah,
Dr. Yes, Shish. Yes, Shish.
so my indication for PK in failed PK is actually those who are having iris abnormalities, or if there is a large sector iridectomy, or if there is anti-segment abnormality, if there is a peripheral anterior synechiae. In such cases, and as Merle mentioned, high astigmatism with the previous penetrating keratoplasty. These are the indications for penetrating keratoplasty in a failed PK. And if there is a significant vascularization, peripheral vascularization, or the surface is very bad, such cases I would prefer doing a endothelial graft. That is DSEK I prefer.
Thank you.